Surgical Rehab Above the Knee Amputation by Kiera Lyons. The differences between AKA and BKA are that AKA stands for above the knee and BKA stands for below the knee. AKA surgeries are less typical, only 27% of people will get those, and BKA surgical amputations are more common and 73% of people are likely to get this type of amputation. For our leg amputation agenda pre-surgery, the patient and family will ideally consult with each member of the surgical and rehabilitation team. This team will fully explore the surgical process with the patient and also explain how rehabilitation will work post-surgery. Your rehab team will provide you with exercises that are good to start with on before your surgery takes place to potentially shorten your recovery time. You will also need to choose a prosthesis. You will be working a lot with this individual over the first year after your surgery, and ideally forming a long-term relationship with them beyond that. So it makes sense to choose someone that you are comfortable with. Recovery and rehabilitation. The first day after surgery can be one of the most difficult. What was previously just an idea is now a reality. Your limb will be treated with special compression bandages or compression socks to help heal the wound quickly. This will help prepare your residual limb for the prosthesis. The team will also advise you on how to wash and take care of your residual limb. Your rehab team will likely include doctors, physical and occupational therapists, nurses, and a prosthesis. Rehab will begin shortly after the surgery to work on the upper body strength and maintain range of motion in your remaining limb. Overall, your rehab can take anywhere from a few weeks to a few months. Emotional rehabilitation. It is normal to go through some levels of depression while you work through the massive changes in losing a limb. You may or may not be assigned a counselor as a part of your rehabilitation team to help you work through these difficult emotions. Osseointegration. Some amputees who struggle with wearing socket prosthetics may choose to undergo a procedure known as osseointegration. This surgical procedure grafts a metal bar directly to the bone in your residual limb that extends out of the skin. The prosthetic can be attached to that piece of metal, providing additional stability and ease of use to the wearer. Resuming an active lifestyle after amputation. As you recover from your amputation, you should be able to resume your day-to-day activities. While there will be an adjustment period, you will soon be able to do almost everything you could prior to amputation. Modern prostheses have made it possible for amputees to live active lives and even compete against able-bodied athletes. There are dozens of adaptive sports and equipment available for people of all abilities. Anatomy of the lower leg. The thigh divides into 3 compartments: anterior, posterior, and medial. These compartments surround the only bone in the thigh, the femur. The anterior compartment contains the vastus lateralis, vastus medialis, vastus medius, rectus femoris, and the gnu articularis. Branches of the femoral nerve lie within the anterior compartment and innervate the musculature. The IT band runs along the lateral border of the thigh, superficial to the vastus lateralis. The sartorius muscle is in the anterior portion of the thigh, more proximally, and in the medial portion more distally, as it travels from the anterior superior iliac spine to its insertion on the anterior medial aspect of the proximal tibia as part of the pes annulus. The medial compartment of the thigh contains the adductor magnus, adductor longus, adductor brevis, and gracilis. The medial compartment also contains the femoral artery vein. Proximally, the femoral artery divides the superficial and deep branches, with the deep branch providing blood flow to the muscles of the thigh and the femoral shaft. The great saphenous vein runs through the medial aspect of the thigh. The posterior compartment contains the long and short head of the bicep femoris, semitendinosus, semimembranosus, and sciatic nerve. Branches of the sciatic nerve innervate the musculature of the posterior compartment. Overview of the surgery. Above the knee amputations, aka, involve removing the leg from the body by cutting through both the thigh tissue and femoral bone. This procedure may be necessary for a wide variety of reasons, such as trauma, infection, tumor, and vascular compromise. In post-care, the patient will go through a prosthesis training in which they will learn how to put on and take off their prostheses, learning how to walk on a level surface, learning how to walk up and down ramps and stairs, sitting down or standing up, and of course, fall training. Rehab in 5 steps. This period of time is the hardest for the patient. Step 1, immediately after surgery, you will stay in the hospital for approximately 5 to 14 days. Your wound will be bandaged, and you may also have to drain your surgery site. Pain will be managed with medication. Physical therapy will begin soon after when your condition is stable and the doctor clears you for rehab. Your first 2 days of treatment may include gentle stretching and range of motion exercises, learning to roll in bed, sit on the side of the bed, and move safely to a chair. Learning how to position your surgical limb to prevent contractures. The physical therapist will help you learn to move about in a wheelchair and stand and walk with an assisted device, for example, a walker. Step 2. A contracture is the development of soft tissue tightness that limits joint movement. The condition occurs when muscles and soft tissue become stiff from lack of movement. Lying in bed with a pillow between your legs may cause a contracture with the leg positioned too far to the side, if this position is repeated over sustained periods of time. Contractures can become permanent if not addressed quickly. Also, contractures can make it difficult to wear your prosthesis. Your physical therapist will show you how to position your limb to avoid development of a contracture and teach you stretching and positioning exercises to maintain normal range of motion. Step 3. Your physical therapist will help you maintain compression on your residual limb to protect it, reduce, and control swelling, and help it heal. Compression can be accomplished by wrapping the limb with elastic bandages or wearing an elastic shrinker sock. These methods also help shape the limb to prepare it for fitting the prosthetic leg. Step 4. The physical therapist will help with pain management in a variety of ways, including the use of an electrical stimulant. Gentle electrical stimulation of the skin helps relieve pain by blocking nerve signals from underlying pain receptors. They can also perform manual therapy, including massage and joint manipulation to improve circulation and joint motion. Another method is by providing residual limb management. And lastly, desensitization to help modify how sensitive that area is to clothing pressure or touch. Desensitization involves stroking the skin with different types of touch to help reduce or eliminate the sensitivity reaction to the stimulus. Step 5. An above-the-knee prosthesis includes a socket, knee joint, ankle joint, and foot components. You will receive a temporary prosthesis at first while your residual limb continues to heal and shrink/shape over several months of healing. The prosthesis will be modified to fit as needed over time. Your physical therapist will teach you how to put your new prosthesis on and take it off, and how to manage a good fit with the socket type you receive. Your physical therapist will help you to gradually build up tolerance for wearing your prosthesis for increasing longer times, while protecting the skin integrity of your residual limb. You will use a wheelchair for getting around even after you get your permanent prosthesis for the times when you are not wearing the limb. Prosthetic training is a process that can last up to an entire year. Your physical therapist will help you learn to stand, balance, and walk with the prosthetic limb. Most likely, you will begin walking using parallel bars, then progress to a walker, and later, as you get stronger, you may progress to using a cane before walking independently without any assistance. You will also need to continue strengthening and stretching exercises. Prosthetics. Exoskeletal. A wooden or urethane foam prosthesis with a hard plastic shell. This prosthetic is relatively heavy, unable to rotate, and has limited customizability, but is durable and long-lasting. Endoskeletal, made up of lightweight materials such as aluminum or titanium. The feet and knees can easily be swapped out. It is also easily adjustable for different activities and active lifestyles. Thank you so much. If you have any questions, email me. Also, here are my main sources.